Hi, good morning, everyone, and thank you for joining us on this morning's lecture as part of Fora Cardiologica, Navigating the Future Cardiology in the Changing Times. My lecture is called Ischemia with No Obstructive Coronaries, or INOCA, and in particular, we will be discussing the findings of the Ischemia trial Ciao Substudy. My name is Dr. Marc Louie Rosario, and I have no disclosures. This is the outline of my talk. I will be discussing background and definition of INOCA, as well as its epidemiology and prognosis based on some registries. We will be discussing some proposed pathophysiologic mechanisms, and then we go to the results of the Ciao substudy of the ischemia trial. Towards the end, we will be discussing possible treatments for INOCA and future studies and directions. As a background, in May 17, 2016, the Cardiovascular Disease in Women Committee of the American College of Cardiology convened a working group or think tank to develop consensus on the syndrome of myocardial ischemia with no obstructive coronaries. They asked the help of the National Heart, Lung, and Blood Institute of the NIH, the American Heart Association, and the European Society of Cardiology. To advance this field, they thought it essential to develop a uniform definition of patient with INOCA. Prevailing elements of a definition summarized from presentations by the think tank members includes patients with the following: stable chronic symptoms suggesting ischemic heart disease such as chest discomfort with both classic and atypical features in terms of location, quality, and inciting factors; objective evidence for a myocardial ischemia from the ECG or a cardiac imaging study such as echocardiography, nuclear imaging, MRI, or spectroscopy at rest and during stress; and the absence of flow-limiting obstruction by coronary angiography, whether invasive or CT angiography, as defined by any epicardial coronary artery diameter reduction of more than 50% or an FFR of less than 0.8. This definition makes us challenge our notion of what ischemic coronary or ischemic heart disease is. Essentially, it challenges the notion of our structural evaluation versus a fully functional evaluation of ischemia. Putting it in another perspective, our notion of ischemic heart disease is challenged by the presence of normal coronary arteries, but the presence of objective ischemia that suggests microvascular dysfunction. We therefore have to think about the pathology that we are presenting. The WISE study, or the Women's Ischemia Syndrome Evaluation, was a prospective cohort of 936 clinically stable symptomatic women who underwent coronary angiography to evaluate symptoms and signs, with the original study done between 1996 and 2000. Almost two-thirds of women undergoing clinically indicated coronary angiography for suspected ischemic heart disease in the original cohort had no obstructive coronary arteries. Extrapolating that to the US population, it is estimated that at least 3 to 4 million women and men with signs and symptoms suggestive of myocardial ischemia have no obstructive coronary artery disease. During a 10-year follow-up in the WISE study, CVD death or MI occurred in 6.7% of those with no evidence of angiographic coronary artery disease, and in 12% of patients who had non-obstructive coronary artery disease. And these deaths account for 31% of all deaths during the 10-year observation period. In a study of cardiovascular events over 5 years, the annualized event rate for cardiovascular events were 16% in the WISE women with non-obstructive CAD and 7.9% in the WISE women with normal coronary arteries. There were also noted increased rates of readmission and repeat angiography due to symptom burden. Women with INOCA are around 4 times more likely than men to be readmitted within 180 days for acute coronary syndrome or chest pain. Large consecutive case registry reports have replicated this heightened risk for adverse prognosis and extended the findings to men. The risk factors associated with increased mortality in this population are older age, hypertension, diabetes mellitus, and smoking. Not associated with increased mortality are sex, hyperlipidemia, family history of premature CAD, or a pretest CAD likelihood. Risk-adjusted analysis found that non-obstructive CAD conferred increased mortality risk compared with patients with no evidence CAD. Aside from mortality, there is noted higher risk for development of heart failure with preserved ejection fraction, and a subgroup of these patients also have microvascular dysfunction of the coronary arteries and possible evidence of inflammation as seen in their biomarkers. In the WISE database, chest pain persisting at 1-year follow-up predicted MACE among those patients with INOCA. Measures of non-obstructive CAD extent and severity, such as in the WISE CAD severity score, and the number of vessels involved also appear to be important in prognosis, but these measures are not well developed and standardized. This sets the stage for further study and analysis of this patient population, which was done with the Ciao substudy of the Ischemia trial, which we will be discussing in more detail shortly. What about INOCA's implications to healthcare costs? Healthcare costs and disabilities similar to those incurred by patients with obstructive CADs have been seen. Angina and heart failure hospitalizations, as well as repeat testing, including angiography, are noted and account for the increased cost. INOCA thus represents a syndrome that warrants more attention and further study. Going to the pathophysiology of INOCA, several risk factors have been identified and described, and these factors may operate alone or in combination. These factors range from increased afterload, such as in hypertension or severe aortic stenosis, demand-supply mismatch, coronary perfusion abnormalities, myocardial diseases, or drug-induced changes. In addition, there are probably some unclear mechanisms that may have not yet been elucidated. One proposed mechanism contributing to INOCA is coronary microvascular dysfunction, defined as epicardial, microvascular endothelial, or non-endothelial dysfunction that limits myocardial perfusion, most often detected as a reduction in the CFR or the coronary flow reserve. Studies suggest that coronary vasomotor dysfunction, even without flow-limiting stenosis, identifies patients at risk of cardiac death. How are CFR and FFR different? CFR is the ratio of maximal hyperemic flow to normal flow, and normal is around 2 to 5 times. This illustration shows us the difference in the macrocirculation and the microcirculation of coronary vascular flow. In the epicardial arteries, as shown on the left-hand side, there is relative responsiveness to flow rather than to other parameters, and this is measured by FFR. In the microcirculation, starting from the small arteries to the arterioles down to the capillaries, different factors or variables come into play. In the arterioles, there is pressure dependence, while in the capillaries, metabolites are mainly responsible for vasomotor function and dysfunction. The assessment of the response of the circulation in the microcirculation is best assessed by the CFR. Coronary blood flow is closely linked to metabolite production, which modulates vascular smooth muscle tone. And coronary vasoreactivity testing is usually done with adenosine or its analog, which is a potent vasodilator. How is CFR different from FFR? As this graph shows, and probably what we already know, an FFR of 0.8 or above is considered normal. If this is associated with the CFR of 2 and above, then this shows concordance in the macrovasculature and the microvasculature. Conversely, if the FFR is less than 0.8 and the CFR is less than 2, then we say that there is concordantly abnormal micro and macrovascular dysfunction. When there is a decreased FFR of less than 0.8, but a normal CFR or a CFR of more than 2, we say that there is probably predominantly focal epicardial disease with little microvascular dysfunction. What we are interested in is this subtype or this population where the FFR is normal at more than zero point 0.8 and the CFR is less than 2, suggesting predominantly microvascular disease. Coronary vasomotor dysfunction, even without flow-limiting stenosis, has prognostic implications. In the Y study, a CFR defined as an invasive Doppler time average peak hyperemic coronary flow velocity over resting flow velocity of less than 2.32 best predicted adverse outcomes in women with INOCA, with a 5-year MACE rate of 27% versus 9.3% for those with a CFR of more than 2.32. And this was found to be statistically significant. Some studies have shown that there is a limited correlation between anatomic CAD severity and functional impairment as reflected in the CFR. Patients with low CFR, independent of angiographic severity of obstructive disease, have increased risk of adverse outcomes. In one study, diabetic patients without obstructive CAD but with impaired CFR experienced cardiac death rates similar to those with non-diabetic patients with coronary artery disease. This table highlights some larger studies that have looked into outcomes in patients with no obstructive coronary artery disease and ischemia. To highlight one of those studies, it was found that in patients with CFR as measured by PET scanning of less than 2.0, the MACE rate was increased at 3 years compared with those with a higher CFR. In patients with CFR less than 2, there was associated 7.8% and 5.6% annualized MACE among symptomatic men and women without obstructive CAD versus 3.3% and 1.7% respectively for those with a CFR more than 2. Moving on from microvascular dysfunction, atherosclerosis appears to be involved. Almost all patients with INOCA with chronic angina studied by intravascular ultrasound to date have some coronary atherosclerosis. In support of this hypothesis, a greater burden of risk factors is associated with more atherosclerosis, but this is concealed by compensatory positive remodeling, yielding diffuse, non-obstructive CAD. In this illustration, we can see that in the presence of significant atherosclerosis, there may be non-obstructive lesions that is seen in angiography. However, it was interesting to note that plaque rupture was not observed in intravascular ultrasound in patients with INOCA from 2 series of patients with chronic angina. 2 single-center reports of non-obstructive CAD presenting with ACS suggest that plaque rupture is observed in the minority and may be responsible for the events. 38% of women and 37% of men and women were found to have plaque rupture. The former study found that plaque ulceration was frequent in addition to late gadolinium enhancement with an ischemic pattern of injury. And in the latter study, it found that plaque rupture frequently appeared and more voluminous plaques with large plaque burden and positive remodeling were responsible for the plaque rupture. What about autonomic dysfunction? Abnormal cardiac adrenergic nerve function is well documented in patients with INOCA, and there is a close interplay between the autonomic nerve system and the endothelium through vasospastic actions of adrenergic and muscarinic receptors. This has been observed among patients experiencing mental stress-induced angina, cold-triggered angina, rest angina, or early morning angina. The main mechanism appears to be related to an abnormal vascular response to acetylcholine. This may be a sign of defective bioavailable vasodilators such as nitric oxide and prostacyclin, or it could be indicative of increased smooth muscle cell sensitivity to muscarinic stimulation. Sympathetically mediated effects of mental stress on the coronary microcirculation may also be deleterious and has been observed in some patients. Moving on to platelet dysfunction. Platelet reactivity, in response to collagen ADP stimulation, decreases after exercise in patients with angina, positive stress tests, and smooth coronary arteries, or INOCA. as seen in this study by Lanza in 2006. As you can see in the graph, healthy patients, symbolized by the diamonds, show a steady platelet aggregation time through exercise and post-exercise. Patients with coronary artery disease, on the other hand, have a decreased aggregation time at peak exercise that persists through the post-exercise period. On the other hand, patients with syndrome X, or patients with angina with no obstructive coronary arteries, have an increased aggregation time at exercise, but then this decreases post-exercise to a level that is even diminished compared to its initial presentation after 120 minutes. Prior work evaluating patients suspected to have myocardial ischemia found that around 40% of women and 8% of men had non-significant coronary artery disease. And most recent analyses have linked angiographic measures of extent of non-obstructive CAD with increased risk of adverse outcomes. These include the number of major vessels included with non-obstructive CAD, the YCAD severity score, and TIMI frame counts. We will probably be seeing studies on the validation of these risk-predicting tools in the importance of non-obstructive CAD in prognosis and outcomes. We now go to the trial that is most relevant to our discussion, the Ciao Substudy of the Ischemia trial. Ciao stands for Changes in Ischemia and Angina over 1 year. The inclusion criteria for the study were patients had to be enrolled but not randomized in the ischemia trial. They had to have had a stress echocardiogram used for enrollment, but have no obstructive CAD on their study coronary CT angiography, which is defined by a stenosis of 50% or more in a major epicardial vessel. In addition, patients should have ischemic symptoms, whether described as chest pain or other anginal equivalents, and they should be at least age 21 years or above. There were 212 participants enrolled from 39 participating sites worldwide in the Ciao Ischemia Ancillary Trial. In total, 21% of patients screened for ischemia had no obstructive CAD on CT angiography, and these were the patients enrolled in the Ciao study. The comparator group included 865 patients with obstructive CAD enrolled in ischemia with a stress echocardiogram. Angina was assessed with a Seattle Angina Questionnaire or SAQ at enrollment at 6 months and 1 year. Stress echocardiography was repeated at 1 year, and importantly, the echo readers were blinded to the CT angiography results. These are the results of the Ciao sub-study of the ischemia trial. Of the 208 INOCA patients, 66% were female, compared with 26% of patients in the ischemia trial with obstructive CAD. The INOCA patients were also less likely to have diabetes, to have a prior MI, and to be smokers or have a history of smoking. However, INOCA patients are more likely to have depression. At enrollment, there was little difference in ischemia severity on stress echocardiography between the INOCA patients and those with obstructive CAD. The median number of segments with moderate or severe wall motion abnormalities on echocardiography was 4, which is considered severe, and that was similar in both groups. With respect to angina symptoms, the median SAQ score was slightly higher in INOCA patients than those with obstructive CAD, and they tended to have more frequent angina. From enrollment to 1 year, half of the INOCA patients had a normalized change in ischemic segments, while 45% were unchanged or worse. Over time, and remarkably, even though the stress tests were quite abnormal at baseline, 50% of them were normal at 1 year. On the flip side, 45% of them were the same or worse. Still, at 1 year, there was no correlation between the changes in ischemia and changes in angina among patients with INOCA, the study's primary endpoint. The hypothesis was that the changes in ischemia would correlate with changes in symptoms. But this was not the case in the Ciao substudy of the Ischemia trial. The findings throw cold water on the hypothesis that the extent of ischemia is responsible for angina in patients without obstructive CAD and suggest that other factors are contributing to patient symptoms. The Ciao substudy adds to the emerging body of literature showing that there are many factors that affect symptom severity. Here we show that the symptom at 1 year were very significantly related to the symptoms at the start of the study, but not related to how much heart muscle had ischemia on the stress test. The study also showed that were stress tests were just as bad as people with severe and extensive coronary artery disease. In fact, the symptom burden was very similar and even a little bit worse. Studies of patients with chest pain have suggested that it is impacted by other factors such as sensory, emotional, autonomic, motor, and cognitive components. As a support to the finding of the Ciao substudy, the Orbita trial showed that PCI improved wall motion abnormalities in patients with stable obstructive CAD, but did not improve angina symptoms when compared with a sham control. There is indeed a large bias in terms of how these patients are treated by ER physicians and cardiologists, and the Ciao substudy is helpful in that stress echocardiography clearly demonstrated the presence of ischemia, something that is frequently questioned when a patient has non-obstructive CAD. Hopefully, this will allow for less bias and allow us to focus on patients' quality of life and their symptoms. The Ciao substudy also showed that symptoms can improve, especially when acknowledged and when the patient is provided support. What are the study's strengths? This is an important study that focused on a subgroup that is usually excluded from interventional trials. However, this is a small trial that was purely descriptive, and there was no invasive testing to elucidate the mechanism of INOCA, such as epicardial vasospastic disease or the presence of microvascular dysfunction, and no randomized treatment strategy was tested. At present, the management strategy for INOCA remains unclear, largely because of the absence of randomized controlled trials. Shown before you is a table of potential therapies for coronary microvascular dysfunction that can potentially help in INOCA. One of them is statins. Multiple prior statin trials using IVUS have documented prevention of progression or even regression of atherosclerosis in coronary arteries. Statins not only lower cholesterol, but also have anti-inflammatory effects. Some studies on fluvastatin and atorvastatin have shown improvement in CFR after 2 months and after 6 months. On the other hand, ACE inhibitors have also been shown to improve exercise tolerance and angina symptoms. In the WISE control trial, women who received quinapril had improved CFR after 16 weeks compared to patients with placebo or in patients with non-obstructive CAD. Current literature has little evidence for effective therapy for microvascular dysfunction for the following reasons. First, studies often include patients with cardiac chest pain that may be attributed to clinical entities other than microvascular dysfunction. And second, because studies have used various CFR cutoff criteria for microvascular dysfunction because there is no guideline consensus on this definition so far. What about non-pharmacologic treatments? Non-pharmacologic treatments can be effective in controlling patient symptoms. These include exercise, cognitive behavioral therapy, and enhanced external counterpulsation, which in a small series have been shown to improve angina symptoms. Cardiac rehabilitation, which involves multiple sessions of cardiovascular exercise, psychological counseling, and nutritional planning, can potentially be helpful in improving exercise capacity and quality of life. What about the next steps? Where do we go from here? Clearly, INOCA is fully understood. Depression, which has been associated with INOCA but is not well defined, could be a therapeutic target. The pathophysiological mechanisms of this process may in part due to epicardial vasospasm or microvascular dysfunction, but more studies are needed. Randomized control trials need to be completed to further discern the underlying mechanisms and potential efficacious treatments of this disease. Moreover, heart failure with preserved ejection fraction and Tachycerebral cardiomyopathy or broken heart syndrome are other poorly understood cardiac syndromes that largely affect women and are also hypothesized to be driven by microvascular dysfunction. Further elucidation about its relationship with INOCA are needed. Lastly, CPFFR in angiographically indeterminate disease can be utilized to better define the pathophysiology of these syndromes and enrolling patients in future studies. CPFFR may also be important in trying to assess for prognosis and management strategies in the future. An ongoing trial currently is the Warrior Trial, a study funded by the U.S. Department of Defense, and it aims to enroll 4,400 women. These women have symptoms of ischemia and non-obstructive CAD on invasive or coronary CT angiography, just like in the ischemia trial. But this is an intervention trial where they will be randomized to medical therapy with high-potency statin and ACE inhibitor plus aspirin versus usual care, and the average follow-up will be 3 years. Primary outcome to be measured will be the first occurrence of death, MI stroke, or hospitalization for heart failure or angina. This is an exciting trial and we await the results. So, in summary, INOCA is a syndrome where there is objective evidence of ischemia, but the absence of obstructive coronary arteries. INOCA appears to be associated with a worse prognosis compared to the general population. The pathophysiology of INOCA remains to be elucidated, but coronary microvascular dysfunction appears to play a significant role. The optimal treatment for INOCA remains unknown, but statins and ACE inhibitors seem to play a role. And lastly, non-pharmacologic treatment, particularly providing support, and cardiac rehabilitation are important in the management of INOCA. Thank you.
Good morning, everybody. Thank you, Mark, for that lecture. Thank you for reviewing us with the INOCA. It's not often that we see a patient where we think they have an ACS or ischemia, and then we do all the tests, and then when we do the angiogram, there's nothing there. No, so this INOCA is for this. You mentioned about cardiac microvascular dysfunction and about the coronary flow reserve. How do you do this? How do you measure it in our setting?
So in the lab, it's just like FFR. So you put a wire into the coronary and you place the very distal tip. There are two kinds: one that measures flow velocity and one that measures the temperature change. And then you administer acetylcholine, and then you see if there is a significant increase with hyperemia. If there is a significant increase of at least 2, which is the usual cutoff, in the WISE trial they found that the cutoff of 2.32 is the one that provides a significant difference between those with good prognosis and bad prognosis. So if you have a CFR that is more than 2 or more than 2.3, then that's normal. If you have less than that, then that signifies microvascular dysfunction.
Okay.
So, but that's not readily available also. It's more of laboratory thing that is used in research. Even in the US, it is done mostly in academic centers for studies.
Mainly for studies. Okay. You have one question here from maybe your friend from Memphis, Tennessee. Memphis, is that correct? Knowing
Yes.
the high from Samuel Versosa, knowing the high prevalence of microvascular disease in women and other tests, would you propose doing in women what we know at this point in time? What other tests? The question is, what other tests would you propose doing in women? With what we know at this point in time.
Right.
Be careful with your question. Is your wife around?
Yes, she's listening. But
Okay.
I think it's already been established by many studies that the pathophysiology in women may not be necessarily the same in men. Because if you saw in the ischemia trial, um, 86% of the participants were actually, sorry, 76% were men. So men usually have obstructive CAD, and the opposite is seen in the Ciao substudy where 60+% are women. For practical purposes, I think for clinicians, the take-home point for the Ciao substudy is to not ignore symptoms and to not ignore stress test findings. Um, and then the question nga is if the patient has an abnormal stress test and has typical or atypical angina, how do you proceed? There is a study that was done in these types of patients. It was a small British study called the Cormica study. All of those patients with that particular scenario, they did invasive testing, and around 40% of them have microvascular spasm. So they treated them with calcium channel blockers, and they improved. Their symptoms improved, their stress test improved. So I think the second take-home point of the Ciao sub-study is that this population of INOCA patients are probably heterogeneous, that the mechanism for their symptoms and the mechanisms for their ischemia may not be necessarily from one factor. There could be microvascular vasospastic angina, they could be microvascular. In which case, for microvascular angina or microvascular vasospasm, the treatment is still unknown. This is what is being attempted to be answered by the Warrior trial, where they will be putting patients on aspirin, ACE inhibitor, and statin. Because as I mentioned in the pathophysiology, these patients with INOCA have abnormal platelet reactivity. They have some form of non-obstructive CAD, which is defined as 20% to 50% stenosis on angiogram. And then to some extent, they have microvascular dysfunction. So I don't think we should send all of our patients with women patients to the cath lab to have an
Mhm.
FFR to, or and give acetylcholine to all of them. But
Yeah.
sometimes a therapeutic trial of calcium channel blockers, for example, as suggested by the Formica trial, might be helpful.
Okay. So yeah. We have one question from Dr. Aguirre. How can estrogen listed as possible treatment be helpful to these patients when there are studies that show that synthetic estrogens cause premature hypertension, CAD, and strokes? Natural estrogen has a different effect on the health of premenopausic women.
Yes, that list that was provided, that table was lifted from the position paper that was drawn by the ACC, by their think tank or writing committee. No, yes, estrogen I think in its natural form is beneficial, but the data on synthetic estrogen is still pretty mixed. You know, if you remember from 20 years ago, we thought that in perimenopausal women, putting them on estrogen might be beneficial, but then later on, it was proven to be not beneficial and maybe potentially harmful. So I think this is continuing to evolve. I think that the exact mechanism is still being elucidated, and we don't know whether those are going to pan out. But there are small scale studies that are being done to try to see which particular therapy will be effective.
Yeah, we have one here. One more question here. What non-invasive diagnostic test can be done to possibly detect INOCA, knowing that the stress test may not be helpful?
Yes, so in the Chow sub study,
Just
they
from Dr.
used
Bernardo.
yes, they used stress echo as the screening tool because stress echo would be more sensitive in trying to detect ischemia because as we know with the regular exercise treadmill test ECG at best the sensitivity is 80%. So if we really have patients with typical symptoms of angina or you're concerned about microvascular dysfunction, to follow the recommendations or what was done in the trial, I think a stress echocardiogram would be helpful
Okay.
in separating those patients who are at higher risk versus patients who are
So we
low
have
risk.
run. Yeah, we have run out of time. I'm sure there are some questions. You can just post it in the chat box. From what I can see here from your lecture, you mentioned about depression to be one of the major factors maybe. Would you recommend anxiolytics to these patients, or aside
Well,
from the non-pharmacologic
uh,
treatment like exercise and
yes,
even meditation?
it was brought up because there were more patients in the Ciao substudy than in the ischemia trial with depression. So they thought that maybe this is a possible therapeutic target. But there has been no randomized trial yet on antidepressants or anxiolytics to see if they will improve patients' objective ischemia and patient symptoms.
Just one more before we end this. There's one question from Dr. Simonet. What about coronary artery tortuosity in menopausal and elderly females as a cause of angina or positive stress test? CCTA can identify this.
Yes, and well, in particular, the tortuosity was not part of the assessment in the ischemia trial. They actually just mentioned obstruction, 0 to 20, 20 to 50, and 50 and above. But yes, there is a lot of shear stress that happens when you have tortuous arteries, and shear stress in the coronary arteries may be a risk factor for vasospasm. They also are a risk factor for atherosclerosis, even non-obstructive atherosclerosis, which is a risk factor for plaque rupture, as was seen in the INOCA patients who eventually had ECS. No, they were found to have non-obstructive, but they had plaque rupture on IVOS.
Yeah, thank you, Mark. I noticed that the majority of the questions are coming from women.
Well, they're the most affected by this, so I think that they deserve the attention, which is why I think Warrior
Okay.
trial and such trials it's about time that we have these trials.
Thank you very much, Mark.